Quite a pleasure to be here with you today. Dr. Stain, I'd like to thank you for that flashback to my general surgery year at UCLA in internship, and it just confirmed for me why I'm not a general surgeon. And although we have tubular structures in common, I just am so glad that I made the choice that I made, but that you all are making the choice that you made. So clearly, when it comes to finding your niche, right out of residency, I was asked to join a private practice and asked to go into private practice by my chair. Who wouldn't join their chair in practice? Well, I said, well, this is great. Absolutely, Dr. Grant, I'll come and join you in practice. And he says, oh, by the way, you can run the practice as well. And I'm like, I just passed part 1 of the orthopedic boards. I can do this. I can run this practice. And what ensued for the next 5 years was more torture and pain than I ever thought imaginable, because running the practice was running a business. And every day I learned that I had had no training or education on how to do so. So I started taking notes on everything I thought we should have been taught, everything I thought we should have learned. And I put together a curriculum that's now CME accredited for physicians. So essentially for physicians by physicians. So my disclosures are, I own the company, Beyond the Exam Room, and I'll be speaking a little bit from our curriculum today. So starting with why, just some of the big picture reasons, I have the pleasure of speaking to you today about financial aspects of practice. The things we don't like to talk about many times are the dollars, although your compensation is not going to be, as Dr. Padgett said earlier, your number 1 go-to look-see in your contract. But monitoring and understanding healthcare economics on a macro and micro level are going to be very, very important. So we're going to talk to you a little bit about that today. You know, certainly we understand that as medical students, we're all excited and happy about going into medicine, and within a very short period of time, many of us feel the burden of practice, and it's usually the non-clinical aspects of practice that tend to be a little bit more stressful. And what we found in a recent survey of final year medical residents that that 49% of these graduating residents said that they received no formal business training prior to exiting their residency, and very, very few felt confident about the business decisions that they were going to make. However, we know on the flip side that when physicians are in the boardroom, the CMS data has shown that 40% of physician-owned hospitals actually tend to get a higher CMS rating than those who are not, than those hospitals that are not run by physicians. After all, we value that patient-physician relationship. We know what goes on in that room. We know the level of care that we provide, and I will contend and maintain that we cannot leave it up to the administrators on every level to decide what we do in that examination room and the full value of it. So I would contend that all of us need to be aware, we need to be involved, and we can't just say, I'm just here to see patients. Those days are over with. In case you haven't noticed, medicine is a business, and I don't think it's going backwards anytime soon. According to one of our recent double AOS surveys of the orthopedic membership, about 30% of our respondents said that they spend about 30% of their time taking care of these non-clinical duties that you see here at the tip of the iceberg, between managing contracts, their fiduciary responsibilities, helping to determine what the quality and value incentives are that are going to be mandated legislatively. I mean, that means that's 30% of your time that you'll be spending working on and thinking about things that you have not been trained on. So it's it would behoove each one of us to make sure that we are able to at least be conversant. And so this is my triangle, my foundational infrastructure that I outlay to all physicians, and it's really based off of Maslow's triangle from our psychiatric days. The basic needs of our physicians at this point, if you're going to be practicing in the 21st century, require that fundamentally here at the base that you have some knowledge about making good career decisions. Business and practice management has to be part of your forte, and the earlier you make smarter financial decisions, the better you're going to be. The earlier you will reach retirement. How many of us know physicians that are working past 70 or 75, not because they want to, but because they have to? Like seriously, how many of us know physicians that are working into their later decades of life? Well, you, as young physicians, have something that can work to your advantage, and it's called annual compounding interest. So the earlier you start investing and understanding the advantages that time affords you, the better off you will be. So I broke up this talk really into just two buckets, and I'll spend a little bit more time on the practice financial piece because we just don't hear enough about it, and what your role will be in terms of your practice's finances. And just based on our last talk, it sounds like those of you who are going into any organization and building a bariatric program, essentially you're building a small business model within that hospital. So you're going to need to know your numbers, and you're going to need to know it from the basics all the way up through the more advanced aspects of that practice. This is a patient encounter. And what we have here is the patient encounter all the way from, this is just an office visit, all the way from check-in to seeing you as the physician to being diagnosed, checking out, and then all of the back-end work that it takes for us to bill and then be reimbursed for that patient encounter and how those funds are reconciled on the back end, all right? So, you know, this is a pretty complex set of processes. This is what it takes for one patient to be seen and for reimbursement to be obtained for that patient. Well, everywhere you see a red dollar sign, anybody want to venture to guess what these are? The red dollar signs? Okay, so the title of the slide, Points of Vulnerability. There are 10 points of potential embezzlement for every patient encounter, for every patient that you see. And this is without there being any operative intervention. So it behooves us to be aware of the fact that for each one of these patients that there are 10 points of vulnerability, 10 places where money can be embezzled. Anybody know what embezzlement is? So that's when money is siphoned away or out of your practice, usually by an employee, right? And many times, employees who embezzle from one physician have embezzled from another physician, and they hop from practice to practice to practice, many times because they know we're not watching these 10 points of vulnerability within the practice. So because we work so hard, because we're going to generate a ton of RVUs, we're going to be putting in a lot of blood, sweat, and tears. We can't just leave it to somebody else to make sure our practice is safe from embezzlement, which means you as the revenue generator in the practice, that's you as the physician, you have to be aware of these points of vulnerability, and you have to take some ownership of this process. And I know a lot of us don't like to talk about that, and it's usually a little bit taboo, but I want you as residents and fellows to start talking to your attendings about their departmental processes. I'm actually adjunct faculty at the University of Louisville, and about 3 years ago, the practice administrator from the Department of Family Medicine embezzled about $2.1 million from the practice. And this was an academic practice, right? And this was a primary care practice. And they couldn't figure out why he was always so shiny. He used shiny clothes and shiny cars. He's always so shiny. So they couldn't figure out why, but it was actually a potential donor to the department that asked to see the numbers and figured out where the embezzlement was happening. So this is something that is very prominent. About 4 out of 5 medical practices will be victims of embezzlement, all right? So it's about 80% because they know as physicians we're not watching. But you're working hard to generate that revenue, so you want to make sure that you are on top of it. I'm going to have a talk following this one about coding and billing, so I won't belabor this point very, very much, but you have to do your own coding. You absolutely must do your own coding. Again, you know what type of work was done in seeing that patient. You know what procedures you performed. You know the details and the complications better than the people who our coders and billers, okay? And it's not that they aren't professionally licensed, but you know the details of that procedure, and so that you don't underbill, you want to make sure that you do your own coding. And then when it comes to assessing and monitoring your practice, again, for those points of embezzlement, here's a new language that you're going to have to learn. There are a whole bunch of abbreviations and financial terms that you're going to become very familiar with as young physicians and even as practicing physicians. So the RVUs that we've heard referred to, that's a measure of your productivity. It actually measures the relative amount of work that it took to see this patient. All right? And depending on the patient's diagnosis and comorbidities, there are going to be different levels of RVUs that are assigned to different patients. The full-time equivalents refer to the employment status of the people who work in your office, or if you are an employed physician yourself. The explanation of benefits form, we'll get into that right away, but if you've been to a physician's office to see a physician, you've actually received an EOB, reflective of that patient, of that physician's care of you as the patient. So you want to become familiar with that. I'll show you one shortly. And then here comes some of the practice financials, which include the accounts receivable. So those are the accounts from which the practice receives payment. So this could be your third-party insurers. These could be patients themselves. But then there are the accounts payable. So these are the accounts or the bills that the practice owes and has to pay out. And the aging report is actually a very, very important report that I'll show you in just a few minutes. If, in fact, you are looking at going into administration and leadership, and again, I think that all physicians should have at least some basic understanding of the revenue generation cycle within their own practice. You won't necessarily get into some of these basic accounting financials within your practice, again, unless you're going into leadership. But just in case you are, there's a very easy way to just kind of get your mind around an accounting assessment of how well your practice is doing financially. I liken it to how we assess medical students when they come to do their fourth-year sub-I. We assess them on 3 different levels. We look at their overall application, which gives us a global view of who they are. And then we look at this 30-day view, their sub-internship, where they come for this fixed period of time, where we can assess their pros and cons, how well they work within the team, but then we get a snapshot of who they are on the interview. Well, similarly, you can assess your practice's financials the same way. Your cash flow statement is going to be an overall summary of the cash that flows in and out of your practice. The profit and loss is going to look at the profitability over a fixed period of time. And then also, too, your balance sheet is going to show you a snapshot today of what the practice owes versus what it owns. So again, if we can do this, which is the only point of my slide. At some point, we are physicians, we can figure this out, because if you are running a business model, a bariatric program, you're going to want to understand the financial and fiscal viability of that practice. One of the worst things that we could do is hand over all of the financial responsibility and accountability to those people who don't have a financial investment in us. Many times, as I coach physicians across the country now, through their negotiations and renegotiations, I've had, a very young physician come and say, well, the hospital, I'm a hospital employee, for example, she said to me, the hospital wants to reduce my salary by $100,000 next year. And I said, so where are your data points? What have you done to monitor your own productivity? So because that doctor did not have her own data that she had been collecting and had been able to compare her numbers to the hospital's numbers, she had a very hard time arguing why they should not reduce her salary by $100,000 in that 1 year. So my point is, we can collect this data, we have to know why, but it's also important that we pay attention to the numbers and why they're coming in. I'll be very, very brief. This is an explanation of benefits form. This is the form that comes into your office from the third-party payer, right, from the insurance company, that says this is how much we are going to reimburse you for the care you rendered to your patient, all right? It is the job of your collections office, your back office, all those people in the back office, You never know what they're doing, okay? They're collating these EOBs. And what they're doing is deciphering how much the practice is going to receive in revenue for seeing that patient, okay? And there are very complex formulas that each insurance company uses to determine the reimbursement based on the ICD-10 and CPT codes for each one of the patients. But to the extent that occasionally you will want to audit some of the EOBs for your patients to make sure that the office is collecting the revenue that is collectible on your behalf. If you did the work, then you want to make sure that the folks in the office are actually collecting the revenue for the work and the service that has already been rendered. So this is what an EOB looks like. Just briefly here, I'll just walk through. Oh man, I didn't bring my glasses. I'll just work through this last patient that we see here underlined in red. I think that is Kelly Doe here at the bottom. And what you can see here is that, and just go follow the red bars for me. Here under the allowed amount, so look at the column that is listed allowed amount and go down to the red bar. You see that the allowed amount is $852.03. Come all the way over to the far right column that says amount paid. How much was paid to the practice for this patient? $0. But what was eligible was $852. Well, what likely happened, if you go all the way over to the right, you can see that this patient's date of service was back in October, right? This EOB came in, if you look at the top, in January. So what happened was this patient's bill probably did not get submitted to the insurance company in a timely fashion. And so it was denied due to failure of timely filing. So it's not that you didn't do the work. It's not that the patient didn't have a good outcome. But if your office did not file the bill or the claim in a timely manner, then you're outside of the revenue generating period. And you're like, well, wait, I did the work. That's right. But it is up to you to make sure, not every day, but on a routine basis, that you understand the concept behind what's going on, because that's $852 you will now not receive, and it can't be attributed to your collections. I have like a million of those examples, but we won't go through them. And then here again is an example of what's called an aging report. Anytime any practice is generating revenue, the revenue comes in over time. So an aging report is the report that every practice administrator reads incessantly, and this is also something that the collections office is monitoring, but this aging report can actually be printed out per physician as well. So here in this practice, we're looking at all of the insurance companies that owe this particular practice money, right? So I have a payer-provider contract with each one of these insurance companies. If we look in the amounts column, the first column to the right of the list of the companies, which third-party payer owes this practice the most amount of money? It's circled in red there. I'm sorry, my pointers. Oh, there we are. So Medicare owes this practice over $500,000 in outstanding revenue. And if you look in each one of the subsequent columns, you can see how far outstanding this revenue, how old these bills are, all right? So currently they have $462,000 outstanding. But over here, and then it continues to increase in the number of days or how old or how long these payments have been owed to the practice, 31 to 60 days, 61 to 90, 91 to 120, and greater than 120 days. Anytime your revenue hits this greater than 120-day outstanding column, you have a less than a single-digit percentage chance that you will ever recoup this money, that you will be able to collect this money from the payer. So the sad part is this is 21%, almost 22% of the total amount of money that is outstanding to this practice is in this greater than 120-day column. You never want that to happen, because the odds of you obtaining that money from the insurance company once it's that far outstanding is minimal. That doesn't mean you didn't do the work. That just means you won't be paid for it, all right? So I'm just trying to make the case that on some level, whether it's monthly or quarterly, that you sit down with your practice administrators and make sure that your AR does not look like this, and that you can have an active role in making sure that it doesn't. Two numbers, if you're going into a private practice, there are two numbers that you want to look at that will have to be calculated. But your collections ratio, you want to see how efficiently the practice is collecting the money that is outstanding to the practice. How efficiently are the people in the back office working on your behalf? And if that practice is collecting about 90% of all of the dollars that are collectible, 90% of the revenue, that practice is being run very, very well. Similarly, if this is a private practice or maybe even a small bariatric model within a hospital, how much is being spent on overhead? You want that overhead percentage to be ideally about 60%, because everything else then moves closer to the profit margin, which can move into your variable pay. But many times, most practices aren't being run this efficiently, where they're only about 60% of their overhead is being covered by cost. But again, two numbers that you may want to consider using in the past. And as I wind down here, us being aware of what it takes to be in practice and understand the financial aspects of practice are critical. It's also critical, especially at this age, as you start thinking about your personal finances. And I know you've seen that online, where we've had so many horror stories about physicians who have not actually taken a huge interest in their personal finances. But one of the things that I recommend is that you do surround yourself with a team of trusted advisors. These are people that you will need to interview and that you will need to build as a team surrounding you. This is you in the center here with that plus sign. That plus sign is another person, like an accountability partner, a spouse, a family member, a sibling, someone who will help keep you accountable when it comes to meeting with these folks on a regular basis and making sure that you're taking care of your business and that these people are working for you. I think every physician who's spoken today, it would be a great physician mentor or coach on your behalf. It is, don't make your career decisions without talking to people who want to help you. That's what we're here for. We don't want to see you step in the same landmines that we stepped in. So a physician coach is one, a financial advisor. Recruiters, I'm kind of plus or minus on them. They have a great set of resources, but depending on whether you're speaking to an in-house recruiter or a recruiter from an outstanding or a separate freestanding company, they may have ulterior motives, but they know how to get you credentialed really, really quickly. Then your banker, you want to have your banker on speed dial. You all are going to be making enough you'll be making six figures. So you qualify for what's called private wealth banking. And so these are people, each bank has a private wealth banking arm. And these are people that can help take care of your transactions without you ever having to step foot in the bank. In fact, sometimes they'll come to you. So I don't think most of us know that, but that's what those folks are there for. An accountant, at some point you're going to want to stop using TurboTax. And I would recommend that highly once your revenue, your salary goes up, your life gets a little bit, complicated. You're going to need a tax accountant. Okay, you're going to need a tax accountant. The health law, I keep pressing the wrong button. The health law attorney that we spoke about earlier, I actually am a huge advocate, not for you to go and sit with an attorney so they can help you decide what your wants and needs are. You should know that walking in the door after speaking with your physician mentors or even coaches, start to gather your list of negotiables and non-negotiables before you get to the health law attorney. But there's going to be some legalese that you're just not going to understand. I had one physician call me last week, and she said, well, I was told I need to talk to you to make sure that I can get out of my contract safely. But I turned in my letter of resignation earlier today. And I said, and you're calling me now? And come to find out, she had not looked at any of the legalities within her contract, including the fact that she was going to have to pay tail insurance, which amounted to $18,000 that she was going to have to come up with in 60 days. in addition to the fact that they could fire her in 10 days after rendering her letter of resignation, where she thought she was resigning with a 60-day notice. I said, no, actually, they can fire you within 10 days from now. So now you're going to need to have another meeting to make sure they're not going to fire you on a short-term basis and to see if they'll contribute to the tail coverage that was attributed or alluded to earlier today. So that health law attorney, along with working with your physicians, physician mentors, these are decisions you don't want to make in isolation, which I think is the key part of this slide. You're going to want to make sure you have several sets of trusted advisors' eyes taking a look at it, because supposedly these people know you. They know your family. They know your aspirations and your goals. These people should be, part of your safety net and network to help you reach your goals and keep you, again, from stepping on landmines. And then overall, this is my last slide. It took me a long time in teaching financial literacy for physicians to figure out how we could get our minds around what we should talk about with a financial advisor, and how we could wrap our minds around building a financial strategy. So what I did was I broke it down into two arms. What you can do if you are being proactive, if you're offensively approaching, what can I do in terms of budgeting, your tax strategy, investing, and estate planning? Now, on the defensive side, you're protecting your income. In case the worst happens, you're going to need disability, long-term care, life insurance. So these are all kind of reactive parts or components of your financial strategy. So understanding that you're approaching your financial strategy globally, but also from two different arms, this gives you a framework around which you and your accountability partner can go in and speak with your financial advisor and reach some sound conclusions about how you can get from where you are now to where you want to be, including that loan repayment and that loan debt. One thing I'll say as I sit down, you'll see 3 stars next to disability. I hope everyone has their own independent, own occupation disability insurance policy, which is separate from the one that your training program is offering you now. You need one that's portable, you need one that's cancelable, and you need one that covers you for being able to do the type of surgery that you do. As a chief resident, I was diagnosed with rheumatoid arthritis. I was only able to operate for about 3 years, and I ran my practice for another 2 after that. Fortunately, as a PGY3, I happened to purchase my own independent disability insurance policy, which covered my capacity to perform orthopedic surgery or not. And because it was an own occupation policy, I was able to receive the benefits. But I can't tell you how many people become injured, who become ill, either short-term or long-term, and they don't have the disability coverage that they need. The guys, 1 in 6 physicians becomes disabled versus the US population where 1 in 8 US citizens become disabled. So your odds of becoming disabled are higher, and we know there's a lot more short-term disability claims being filed due to anxiety, stress, and burnout now as well. You need your own policy before anything happens. And with that, I believe these are the take-home points. Monitoring your own billing, your own productivity, and building your comprehensive financial strategy with a team of trusted advisors. Thank you very much.